This lecture is entitled Prostate MRI Using PI-RADS. I thank you for your interest. My name is Andrew Rosenkrantz. I'm an Associate Professor of Radiology and Urology, as well as Director of Prostate Imaging at NYU Langone Medical Center. And this talk is supported by an AUR RSNA Education Scholar Grant. This is my disclosure for the talk. Begin with a representative case of the role of prostate MRI in patient management. And these images are from a patient with a rising PSA who had not undergone a prior prostate biopsy. The images show what we designate as a PI-RADS category 4 lesion in the right posterior peripheral zone, demonstrating focal decreased T2 signal, decreased ADC, increased signal on a high B value, diffusion weighted image, as well as focal early enhancement. All typical features of peripheral zone tumors. This lesion underwent a targeted biopsy using a real-time MRI ultrasound fusion system, which demonstrated this to be an intermediate grade tumor having a Gleason score of 3+4. The patient concurrently underwent a 12-core non-targeted systematic biopsy, and that biopsy in fact did not pick up the lesion on the right, which the MRI shows quite well, although did pick up a low-grade Gleason score 3+3 tumor on the left, which the MRI does not show. So this case illustrates how the value of prostate MRI in large part really stems from it addressing challenges of conventional systematic prostate biopsy. It's estimated that over 1 million prostate biopsies are performed annually in the U.S., and with a traditional biopsy scheme, significant cancers are commonly missed or undersampled, and insignificant tumors are frequently detected. The standard biopsies are costly, associated with discomfort and side effects, and importantly, there's often a lack of confidence in the results. So prostate MRI associated with targeted biopsy can really help address these issues. There have been significant improvement in the ability of MRI to detect and localize tumor within the prostate over the past decade. Now, with current protocols, MRI has consistently high sensitivity for high-grade tumors and low-grade tumors often being undetected. So this now allows for a new approach using MRI to select patients for biopsy and to define the biopsy targets. So to get into doing this in actual clinical practice, in terms of the details of clinical protocols and implementation, we'll start off by discussing hardware. So there are really two key hardware issues: field strength, 1.5 versus 3T, as well as the coil selection, endorectal coil versus an external phased array. So this is a challenging issue with a continued lack of consensus among radiologists, and strong opinions on both ways. So if we look at what PI-RADS version 2 tells us, it doesn't really take a single firm stance, and this is quoting from the current PI-RADS document. In some areas it states that credible, satisfactory results have been obtained at both 1.5 and 3T without the use of an endorectal coil, and that both field strengths can provide adequate and reliable diagnostic exams. Elsewhere, PI-RADS states that its authors prefer, use, and recommend 3T for prostate MRI, and that with some 1.5T systems, the endorectal coil is indispensable. In terms of what to take away from this, elsewhere the document states, given the variability of MRI equipment, PI-RADS recommends that supervising radiologists strive to optimize imaging protocols in order to obtain the best and most consistent image quality possible with the MRI scanner used. And this is a really important point. We have to make the hardware selection that makes the most sense for our practice, and then work to optimize the image quality using the hardware that one chooses. In other words, while certainly the hardware selection is important, there's also a large role for how the sequences are adjusted and optimized, and really doing the best we can with whatever equipment we choose to use. If we have contemporary equipment and optimized acquisition parameters, then we can perform, quote, reliable diagnostic exams that can help patient care independent of field strength and coil selection. So moving along and now discussing individual sequences that make up a prostate MR protocol. T2 weighted imaging has really been the mainstay of prostate protocols since the early descriptions of this exam. Prostate MR exams typically include T2 weighted imaging in axial as well as at least one additional plane. Although T2 weighted imaging alone is not sufficient for prostate cancer detection and localization, and this relates to the often heterogeneous appearance of the peripheral zone on T2 weighted images, with numerous benign causes of decreased T2 signal, including inflammation, atrophy, scar, as well as other conditions. And this non-specificity of T2 weighted imaging very limited the widespread use of prostate MRI prior to the advent of more recent sequences. Here we have two patients with heterogeneous peripheral zone in T2 with patchy areas of decreased T2 signal, and neither of these patients have ever been shown to have tumor on any prostate biopsy that they've undergone. So the performance of prostate MRI for tumor detection can be improved greatly by the inclusion of diffusion weighted imaging, which substantially improves the reliability of interpretations. And it's been the real advent and emergence of prostate diffusion that has to be considered a key reason for the surge of interest in clinical adoption of prostate MRI in recent years. And this is now considered an essential part of routine prostate MRI protocols. So to look at some examples, in the initial descriptions of prostate diffusion, the key focus was on the ADC maps provided by this sequence, with numerous studies showing improved accuracy by combining the conventional T2 weighted imaging with the ADC maps. So here we have T2 weighted images from two different patients that showed diffuse decreased signal, and these by themselves would be difficult to read. There could be tumor on just the right, just the left. Bilaterally, there could be no tumor. We wouldn't really be entirely sure. But then when we look at the corresponding ADC maps, we see in the first patient this area of focal decreased ADC on the left, in the bottom patient this area of focal decreased ADC on the right, and both of these regions corresponded with the patient's dominant tumors on subsequent prostatectomy, really showing the role of the ADC map for giving a more precise and confident localization of patients' dominant tumors. In more recent years, a number of studies have shown that when assessing prostate diffusion, there's value not just in the ADC map, but also in very high B-value images. And these are B-values higher than we're used to using in other organs. And in fact, B-values in the range of about 1,400 to 2,000. And the concept here is that benign prostate tissue, in fact, is often not fully suppressed at a B-value of about 1,000, and still showing residual high signal there. But whereas when you go to even higher B-values, we do get greater suppression of the benign tissue, which can improve the conspicuity for dominant lesions. This is a patient who had a dominant tumor in the right transition zone on prostatectomy. At B1000, the entire prostate shows increased signal, and the lesion isn't all that apparent. Whereas at B1500, much of the benign tissue now suppresses, and we better appreciate increased signal within the lesion. In terms of actually incorporating these very high B-values into our protocols, the high B-value images can be challenging to acquire. As we increase the B-value, the SNR decreases, and we have greater issues with distortion and other artifacts. So an alternative approach can be to use what's described as computed diffusion-weighted imaging. In this case, the high B-values are mathematically generated from the lower B-values and not directly acquired. This provides the image contrast of the very high B-values, and as well as good quality in terms of distortion and artifacts, since they're not directly acquired, and also does not require the additional time needed to compare with standard B-values to get those very high B-value images. So as an example, this was a patient with a dominant tumor on the left, and here we have the acquired B1000 image. There's diffuse increased signal throughout the prostate, including in benign regions. with just some slight relatively greater signal on the left. Here at a computed or extrapolated B1500 image, much of that benign tissue now suppresses with more apparent focal increase signal on the left in the region of the patient's dominant tumor. So now, just to show several examples of how diffusion-weighted imaging can really help in localizing dominant lesions. This was a patient with a prior negative biopsy. The PSA wasn't even all that high, in this case 1.8. The patient did undergo a prostate MRI. The T2-weighted image shows diffuse decreased signal. Very tough to localize anything, any dominant lesion with confidence. Now, if you look at the ADC map and in a computed B1500 image, we see this focal region in the right anterior prostate with low ADC, increased signal on the high B image. It stands out better at B1500 than at B1000. And on a targeted biopsy, this was a Gleason score 3+4 tumor. An additional example, this is a patient who had no prior prostate biopsy, but a PSA of nearly 10. Again, T2-weighted image shows just a heterogeneous prostate, no clear dominant lesion. Here the ADC shows focal low signal on the left, which also had a focal increased signal on the computed B1500 image. Targeted biopsy of that lesion, as in the prior case, showed a Gleason 3+4 tumor. It's been suggested that these very high B-value images can also be a particular value in the transition zone for separating BPH nodules from transition zone tumors. This is a patient who has extensive BPH. The ADC map shows some shows an area of low ADC in the midline anteriorly of the transition zone. There are other smaller foci of low ADC within this zone. On a computed B1500, we see focal increased signal within that area anteriorly. That stands out relative to the rest of the patient's transition zone. And this as well was tumor untargeted biopsy. And one additional example, this is a patient, the PSA of about 5, no prior prostate biopsy. On MRI, the T2-weighted image, really no focal lesion stands out. The ADC map, again, we may not call anything of just having this image by itself. On a B1500 image, the prostate is essentially entirely suppressed, other than this crescentic area of focal increased signal along the left anterior stroma of the prostate, which corresponding, I guess we could suggest there is some matching decreased ADC. And on targeted biopsy, actually this was quite a high-grade lesion, a Gleason 4+5 tumor. So in this case, the MRI, and in particular the high B-value images, were very useful for guiding the tumor's detection. So given the role of diffusion-weighted imaging, it's critical that we get high-quality high B images and ADC map to guiding reliable and accurate interpretation. However, this is the sequence most prone to anatomic distortion and warping, with rectal gas being a particularly key source of a possible severe artifact on the sequence, and in fact can actually render the sequence to be non-diagnostic. Here we see a sagittal T2-weighted image in a patient with a very distended rectum, and when we look at the diffusion-weighted image and ADC map, we see that artifact from this distension is essentially compressed. The prostate has led to this band of artifactual increased signal and really made it not possible to give a reliable interpretation with diffusion. So various aspects of patient prep have been attempted among different centers to try to address this issue, although approaches are inconsistent and there's really no data informing us as to a single optimal technique. Some centers are using an enema or a laxative to achieve an empty rectum. It's even been mentioned to use a small catheter or suction through a small catheter prior to the exam. Say if initial scout images show a very distended rectum, to help try to avoid the artifact. We at our center we routinely give the patient instructions before the exam to evacuate and try to empty their rectum we tell the patients it will help us get clearer images. And also glucagon can be used to reduce any peristalsis, although this will have short half-life and may not last throughout the entire exam. So now just one additional sequence to talk about that's included in many prostate MRI exams, and that's dynamic contrast enhanced imaging, or DCE. So PI-RADS advises us to do DCE with a rapid temporal resolution of at least 10 seconds, with under 7 seconds being preferred. And at least in PI-RADS, it's indicated we can evaluate this with a visual assessment, in which we're essentially looking for early enhancement simply by just scrolling through serial acquisitions, which we can do using a standard PACS. So this visual approach is probably the most widely applied approach in clinical practice for evaluating prostate DCE, and is supported by available data on the topic. So note that washout has been removed as a consideration in most recent interpretation schemes in comparison with some earlier literature on the topic. And in this regard, the kinetic curves and parametric mapping have really become controversial, with the recent data suggesting that there is limited added diagnostic value compared with simply looking for the focal early enhancement. PI-RADS indicates that some of these more complex approaches to evaluating DCE may be helpful, but are not formally advised. So here we can see a visual analysis, this little focus of early enhancement within the left peripheral zone, and just seeing the serial time points, we can approach that initial rapid wash in that area. And again, here we see that little focus. So for some examples, and this is just starting with a more obvious case, a large tumor on the left on T2, decreased ADC, and just visual assessment, we see the focal early enhancement within the lesion. Here, a smaller lesion, focal decreased T2 signal, decreased ADC, and here we see, the lesion's focal early enhancement relative to the remainder of the peripheral zone. In terms of the clinical utility of DCE, I think once we identify a positive abnormality in DCE, it's important to then scrutinize that area closely for a correlate on the other sequences. Nonetheless, we still base our interpretation primarily on what we do identify on T2 and diffusion. In terms of the role of DCE, it can serve to raise our confidence in an abnormality identified in other sequences. It can assist in final suspicion scoring in challenging cases, say if there are equivocal findings on high B or ADC. It can be useful if other sequences are suboptimal, say there's motion on T2 or artifact and distortion on diffusion, and it can direct our attention to areas that otherwise may have been overlooked on the other sequences. So I think in terms of showing its value, here we have a patient with a very large transition zone, extensive BPH. It's compressing and effacing the peripheral zone. If we just had T2 and diffusion, we might just kind of read this as negative, say there's really no dominant lesion. However, on the DCE, it really draws our eye into this focal early enhancement in the posterior right peripheral zone. It kind of brings our attention to that region to more closely inspect other sequences. And in fact, there is a much more subtle but a little tiny small correlate in the other sequences with some focal low ADC and low T2 and some mild increased signal on the high B image. DCE can also help for tumors in more challenging locations. Some tumors have a crescentic or thin subcapsular configuration. In this case here on the T2, this region posteriorly down by the apex, again, it's kind of along the capsule, which itself is T2 dark and may be tough to assess. On the DCE, we do see this focal increased enhancement in that region, which is bright in the high B and dark in the ADC, and this was a high-grade tumor on targeted biopsy. The distal apex, again, can be difficult to evaluate. The prostate doesn't really have a distinct capsule by the apex, but its glands just kind of gradually taper or peter out, and this can create some challenges on T2. Here we see this focal early enhancement on DCE, showing expected signal abnormalities on ADC and high B, and this as well was a high-grade tumor on targeted biopsy. When evaluating prostate DCE, we routinely get subtracted images, which can be helpful, particularly in the setting of patients with post-biopsy hemorrhage. This patient here has a dominant lesion in the right posterior peripheral zone on T2 and ADC. This was a post-contrast image, but it's confounded by diffuse increased T1 signal, intrinsic T1 signal from a recent biopsy. On the subtracted image, it now subtracts out that increased signal, and we can now see the corresponding focal increased enhancement within the patient's tumor. One thing to be aware is that DCE does not show the consistent association with grade, as does DWI. That is, whereas diffusion really is more reliably showing high-grade tumors and may not detect low-grade ones. With DCE, it might show a low-grade lesion, and then we may have some high-grade tumors that do not have a DCE correlate. In this case here, this was a high-grade lesion with focal decreased T2 signal, decreased ADC, bright on the high B image. On DCE, there's just kind of this symmetric diffuse enhancement pattern with really no convincing focal DC abnormality to correspond with the lesion on the other sequences. So now I'm going to mention a number of potential diagnostic pitfalls that are important to keep in mind when interpreting the exam. These can be sources of possible overcall, and I'd list first and foremost the central zone, which for somebody who's with less experience or is new to these exams can really present a challenge. So the central, just in terms of terminology, this is a distinct zone from the transition zone. This is histologically, embryologically, anatomically a separate region. It's a potential source of miscall for a high suspicion lesion, if not for even extraparticular extension or seminal vesicle invasion. So basically, what can happen is somebody can, if they're not aware of this structure, can actually misinterpret the entire central zone itself as a large tumor. So the central zone is a symmetric structure at the posterior prostate base. It's this entire region here. So this is sitting above the peripheral zone and posterior to the transition zone. This encircles the ejaculatory ducts, which we see as these little foci of T2 bright signal posteriorly. You have this wedge shape on the coronal images. So we just kind of have to recognize that the structure sits in this position, and it's just normal anatomy and not suspicious for tumor when recognized as such. So the central zone can show decreased ADC, and given some distortion on the ADC map, so it can sometimes create a pitfall in that image as well if we're not aware. But again, we just have to correlate carefully with the other sequences. Here we see this low ADC at the base on the ADC map, but on the T2 image, it has the expected configuration of the central zone, kind of this lobular appearance, symmetric on the midline, encircling the ejaculatory ducts, with the basal aspect of the peripheral zone visualized out laterally. Another potential pitfall in diffusion with images, the neurovascular bundle. And what I'm getting at here, sometimes on the ADC map, given distortion, the decreased ADC within the neurovascular bundle may actually look like it's a focal lesion within the prostate itself. And again, here we just have to correlate with other sequences. Here we see the low ADC, and we look at on the T2, it's actually this structure here, which is sitting outside the prostate capsule, and we see the correlate neurovascular bundle on the contralateral side. And we can even just scroll through the images and follow this up and down as a tubular structure and not tubular structure outside the prostate and not a true lesion. And it was actually the signal void in the high B image that did not correspond with any actual lesion. And sometimes there are going to be just some benign processes that will mimic tumor, and on a single image set or an image set at a single point in time, we just cannot reliably differentiate. So a big mimicker in the peripheral zone is prostatitis. Focal prostatitis can look very much like tumor. It may have more of a geographic shape or less clear mass-like configuration. Here we see this region of low T2 signal and low ADC in the right peripheral zone, though it does have somewhat linear margins. This underwent a targeted biopsy and was prostatitis. On a 1-year follow-up MRI, we just see diffuse decreased T2 signal without really a focal lesion in that region. In terms of a key mimic in the transition zone, this would be stromal BPH nodules, which can be very difficult to differentiate from transition zone tumor. Here we see this focal region of rounded region of low ADC that also showed a low T2, and some concern had been raised at the time of interpretation. This underwent targeted biopsy as well and came back as just benign BPH. For these, morphology and texture can be helpful. Transition BPH nodules will have more of a rounded shape with very distinct edges. They're well marginated. We may even see a thin T2 dark capsule around them, whereas transition zone tumors will have less distinct edges. And the very high B-value images, as mentioned before, can also be helpful. So moving past interpretation and now into reporting. Standardization of interpretation and reporting of prostate MRI is critical to really maximize the clinical impact of the exam across centers and practice settings. And I think despite the role of MR, it's really been inconsistent reporting between centers and radiologists that have been a major hurdle to wider adoption of prostate MRI. And we're now really getting beyond that and having solutions to this through the use of standardized reporting systems. And we're getting at this with the Prostate Imaging Reporting and Data Systems, or PI-RADS. There was an initial version from the European Society of Urogenital Radiology in 2012. Version 2 was initially launched in December 2014. This was a joint effort of the American College of Radiology, ESUR, and the Atomy Tech Foundation. With PI-RADS, it calls for report structure to provide detailed information on a per-lesion basis. With this approach, where we clearly identify suspicious lesions, giving for each lesion a suspicion score from 1 through 5, its location, size, and any associated extraprostatic extension. PI-RADS version 2 provides fixed criteria to guide lesion assessment, with separate criteria for giving a 1 through 5 score for both T2 and diffusion in each of the peripheral and transition zone, reflecting lesion signal, margins, morphology, and size, and for diffusion, reflecting both ADC and the very high B-value images. DCE is categorized in a binary positive versus negative fashion based on whether we visually detect an early enhancing focus corresponding with the T2 and diffusion finding. These are the definitions for 1 through 5 using PI-RADS, basically from very low to very high suspicion based on our perceived likelihood of clinically significant disease. This table shows the scheme for deriving the overall PI-RADS category within the peripheral zone. And this uses a dominant sequence approach, that within each zone, a particular sequence is dominant in giving the overall category. In the peripheral zone, diffusion is the determining sequence. For the most part, the overall category reflects whatever the diffusion score is, regardless of the other sequences. So if diffusion is 4 and T2 is 2, then the overall category is 4. The one exception in the peripheral zone is that a positive DCE will bump a diffusion 3 to an overall PI-RADS category of 4. This table shows the scheme for deriving the overall score in the transition zone, where T2 is dominant. That is, T2 is the determining sequence. So in the transition zone, if the T2 score is 4 and diffusion is a 2, then the PI-RADS category is a 4. The one exception in the transition zone is that a diffusion score of 5, diffusion score of 5 bumps a T2 score of 3 to an overall category of 4. This table provides a criteria for deriving the 1 through 5 diffusion score, which actually applies in both zones. And I'm not going to actually read through this in full detail, but to make a few points, for diffusion, 3 through 5 all require the presence of a focal lesion, versus something that's, say, more indistinct or geographic. 4 require that a lesion be markedly dark in ADC and markedly bright on a very high B-value image. 5 is like a 4, but also at least 1.5 centimeters, or shows gross extraprosthetic extension or invasive behavior. So to see how this works, here we have this kind of vague, ill-defined lesion in the posterior left peripheral zone in T2. In this case, this was considered to have a T2 score of 3. DCE, this was a case where we were using kinetic mapping. There was no focal early enhancement. This was DCE negative. But on diffusion, we do see focal very decreased ADC with focal very increased signal on a high B image. So diffusion was given a score of 4. And based on the dominant sequence approach, we don't average these numbers. We don't we don't average them. But the diffusion was a 4. So in the peripheral zone, overall PI-RADS category of 4. So these numbers, I think it's very important and helpful to give clearly and unambiguously our category within the reports. This is a patient with 6 prior negative prostate biopsies, but had a progressively rising PSA as well as an elevated PCA3. This is a urinary mRNA-based marker. On the MRI, we see this left anterior transition zone lesion with some ill-defined margins. This was given PI-RADS 4 at the time of interpretation, and having that very high PI-RADS category was useful for making the clinical decision to perform yet an additional biopsy. Had it had a lower category, a repeat biopsy may have been deferred, and then this came back tumor on targeted biopsy. And again, in terms of value of potential low score, this was a patient with a prior negative biopsy, PSA of 4.8, MRI. We had a nice clean prostate, nice increased signal throughout the prostate on T2 and ADC. This was given a PI-RADS 1, which has over 95% negative predictive value for significant cancer in a number of studies. And again, if we had just said, heterogeneous prostate, or kind of an equivocal reading, that may have not really had enough confidence to avoid a repeat biopsy, but giving the score of 1 was useful for a decision to defer a repeat biopsy in this patient. So one situation that occasionally will be encountered is just a diffusely heterogeneous prostate with potentially numerous lesions we could describe, and this can be challenging. In general, we'll report just the dominant foci, those with the highest suspicion categories. In our practice, we typically report 1 or 2 lesions, occasionally 3, not really more than that. PI-RADS actually states that reporting of low suspicion or PI-RADS 2 lesions is optional, as those lesions are so overwhelmingly benign or very rarely just a low-grade tumor. So this patient here has a diffusely heterogeneous prostate, multiple areas of low T2 signal, but on the ADC map we see this dominant focus on the left, and this was reported as a PI-RADS 4 lesion, and we didn't really describe all these other less suspicious foci. So in terms of lesion localization, PI-RADS version 2 provides this prostate sector map which I think can be useful to guide us in terms of the level of detail to give for lesions. It notes 4 zones: the peripheral, transition, central, as mentioned earlier in this talk, as well as the anterior fibromuscular stroma. Peripheral zone lesions are classified as posteromedial, posterolateral, or within the anterior horn. Transition zone lesions are classified as anterior or posterior. So for anterior or posterior, we just can divide the prostate in half in the AP plane. For medial or lateral, it suggests we can use the lateral margin of the transition zone. So these next set of slides get really important. PI-RADS version 2 PI-RADS version 2 gives a number of caveats to guide us in interpretation. That it really warns us that we have to not be overly dogmatic in applying the criteria, but to be aware of other confounders or potential mimics or pitfalls. And we're going to go through a number of these. So one thing PI-RADS states is that mild signal changes on T2 in diffusion that are not rounded but rather indistinct, linear lobar diffuse, are less likely to be malignant. And these can be given PI-RADS 1 or 2 depending on the specific case. It notes elsewhere that bilateral asymmetric signal anomalies on any sequence are often due to normal anatomy or benign changes. So in a case like this, we see these symmetric or fairly symmetric bilateral non-mass-like areas of mild signal changes on the various sequences. And again, we just have to kind of recognize this normal mild heterogeneity that we'll commonly see and not be overly suspicious about such changes. In addition, PI-RADS states that homogeneous or heterogeneous nodules in the transition zone that are round, oval, well circumscribed and encapsulated are common. Often they demonstrate restricted diffusion but are considered to be benign BPH. These do not have to be assigned a PI-RADS category, though occasionally can, so the probability is very low. And this gets out to some earlier examples. Here we see this spherical nodule in the right transition zone with decreased T2 signal, but very clear edges, even a potential capsule around it. It just kind of has swirled enhancement on DCE, similar to the rest of the BPH in the transition zone. It's a mildly dark in ADC, but does not show focal increased signal on the high B image. And this is just a stromal, and this stromal BPH nodule is fairly typical features, the rounded shape, the margins, even how it looks on the other sequences. And we recognize it as stromal BPH. We do not need to create suspicion if we try to be overly dogmatic in looking at the criteria, but can just describe this as a benign nodule. On a related note, PI-RADS states that an encapsulated, circumscribed, round nodule in the peripheral zone is likely extruded BPH, even if ADC dark. PI-RADS category is 2. So the idea here is that on occasion, these BPH nodules can be extruded or displaced into the peripheral zone, in which case they can actually be somewhat challenging, because these nodules will show low ADC and will show early enhancement, which in the peripheral zone can create quite a bit of suspicion. So here we see in the right anterior peripheral zone this focal low ADC, increased signal in a high B image. There's early enhancement, but here we actually have an image this was from a 3D thin section T2, and we can see it actually has a thin black capsule. It's an encapsulated lesion, and we can see it almost hanging off the transition zone with an obtuse edge and texture very much like that of the BPH. So this is just an extruded BPH nodule into the peripheral zone, and we recognize it as such. We can assign this lower suspicion despite its features, in this case, on the diffusion and DCE. An additional caveat, PI-RADS states that benign findings in normal anatomy, i.e. fibrosis, stroma, and blood products, may exhibit minimal signal in both T2 and ADC. However, in contrast to significant cancer, these will also be markedly hypointense on all diffusion-weighted images. In other words, there can be a T2 blackout effect, that areas that are dark on all the B images will then lead to low ADC, but this should not be given the same level of suspicion as would be given for true restricted diffusion that would have accompanying high or increased signal on a high B image. As an example, this lesion has decreased ADC, when we look at the this is decreased ADC, but when we look at the B1000 image, it's actually not bright, but dark. So then to explore further, we go back to the initial B0 image, and we see it's dark there as well. So this is just a signal poor region. It's dark in all the Bs. It'll be dark on the ADC. And this doesn't really reflect restricted diffusion, but just other benign processes causing essentially a T2 blackout type effect. Elsewhere, PI-RADS states that while primarily evaluating ADC maps using a qualitative visual assessment, an ADC threshold of 750 to 900 may assist in identifying significant cancers. And this just gets at that while we're largely using a visual assessment to decide if a region is really showing ADC, it can help to also actually quantify the ADC values, whether using an ROI, as in this example, or just using a pixel tool and sampling within the lesion, getting a sense of individual pixel values. In this case here, we see this ROI at an average value of 780. And if we're not sure visually if the lesion truly is showing marked decreased ADC, PI-RADS is giving us an approximate threshold range that we can use to guide the assessment. And I find this actually to be helpful for some lesions when I'm unsure that can be equivocal. Just a couple additional statements from PI-RADS of relevance. Quote, a PI-RADS category should be based on MP-MRI findings only and should not incorporate other factors such as PSA, DRE, clinical history, or choice of treatment. Again, we should be reporting what the images show. So, for example, even if we know that the patient had a prior positive biopsy as it has known cancer, if we don't see any lesion on the MRI, again, we should report it as such, and that can actually be very helpful prognostic information for a patient with prostate cancer that say they have a negative MRI. And also that lesions should be measured on ADC in the peripheral zone and on T2 in the transition zone. If measurement is difficult or compromised on those sequences for the given zone, the measurement should be made in the sequence that shows the lesion best, and in the report indicate the image number, series, and sequence used for measurement. So the very final topic I'll cover more briefly in this talk is the MRI-targeted prostate biopsy. And really 3 approaches to this have been described in the literature. Cognitive biopsy, so this is really using no specialized equipment. The biopsy operator looks at the MRI, gets a sense in their mind of where the lesion is, and then at the time of the biopsy, just on visual estimation, tries to take some course from that area. Direct MR-guided biopsy within the bore of the MR gantry itself, as well as real-time software-based MRI ultrasound fusion biopsy. So in other words, targeting under ultrasound, but fusing to the MRI to sample the lesion. And there's data supporting all 3 of these methods as improving detection of clinically significant cancer, at least compared with a standard non-targeted systematic biopsy. So I'm going to comment in a little more detail about the software-based MRI ultrasound fusion approach, which is gaining rapidly in interest and adoption by urologists, and it's what we use in our center. Again, so this uses software for real-time fusion of the modalities. There's additional hardware for directing the needle under ultrasound to the MRI-defined lesion. This is often performed by urologists during a clinic visit. It's easy for urologists to integrate into their practice. They're familiar with ultrasound. It's quick and accessible to them within routine workflow. The way this works, the MRI images are loaded into the biopsy system, and the targets are annotated in advance. And the urologist can readily perform systematic sampling during the same biopsy session. So there has to be an initial planning session in which typically the radiologist markates the boundary of the prostate on MRI as well as the boundary of lesions. The operator during the biopsy does an initial sweep of the prostate ultrasound as well, and its boundaries get demarcated there, and then typically a combination of rigid and elastic registration are used to co-register the modalities and guide the biopsy to the MRI target. In terms of the role of PI-RADS in this, for PI-RADS categories 1 or 2, significant cancer is very unlikely. A targeted biopsy of the lesion will typically be deferred given that the lesion is low risk. Nonetheless, a careful decision about performing a standard biopsy still needs to be made based on consideration of other traditional risk factors, and as well as any other ancillary markers. For PI-RADS categories 4 and 5, these have a greatly elevated risk of significant cancer, and a targeted biopsy would typically be warranted. PI-RADS 3, I think views on this are still evolving. Whether to perform a targeted biopsy at this point will still be tailored to the patient's individual risk profile. And now, just to look at some of the relevant data, there was a recent meta-analysis regarding results of fusion-targeted prostate biopsy. This included 14 studies with a collective sample size of over 2,000. Compared to the standard biopsy, systematic biopsy detected more significant cancers using fewer cores. Some studies confirmed a lower detection of insignificant cancers using fusion biopsy. And there also was a large prospective study of fusion biopsy with over 1,000. This was over 1,000 patients that appeared in JAMA. And in this study, fusion-targeted biopsy versus standard biopsy resulted in 30% more high-risk cancers, but 17% fewer low-risk cancers. And, quote, the number needed to biopsy with standard biopsy, in addition to targeted biopsy, was 200 men to diagnose one additional high-risk cancer. But for every additional case of high-risk cancer diagnosed by standard biopsy, 17 additional cases of low-risk cancer would be diagnosed. So that concludes this lecture. Just some final takeaway points. So for diffusion, be aware of technical optimization, including role of very high B-values. DC can help to detect some tumors, but have a lesser impact on final scoring. PI-RADS version 2 is now being adopted for standardizing reporting. And fusion biopsy can lead to increased detection of high-grade tumor, decreased detection of low-grade tumor with fewer biopsy cores. So again, I thank you for your time and attention. I hope this talk was useful. And then that concludes the session.